All right, we're going to go ahead and get started. Welcome to the Bay Area Council's Bay Area Impact webinar series. I'm Ranjana Clark, Head of Global and America's Transaction Banking and Bay Area President for MUFG Union Bank, and a member of the Bay Area Council Executive Committee. Today's topic couldn't be more timely or more important. The COVID pandemic is raging across the Bay Area, California, and the nation. Infections, hospitalizations, and deaths have all been soaring in recent weeks. The good news is that companies like Pfizer have developed an effective vaccine that promises to end the pandemic. But many issues and questions remain, with the vaccine distribution still in the early stages, and some would argue already behind schedule. Today, we are fortunate to have two incredible leaders to discuss these important issues. Dr. Erica Pan is acting public health officer for the state of California and has chief responsibility for the state's vaccine distribution program. Dr. Sue Desmond-Hellmann is a world-renowned pharmaceutical researcher and executive, the former Chancellor of UC San Francisco and former CEO of the Bill and Melinda Gates Foundation. She also serves on the board of Pfizer, one of the companies at the forefront of developing COVID vaccines. She's also a recent inductee to the Bay Area Council's Business Hall of Fame. Welcome and thank you, Dr. Pan and Dr. Desmond-Hellmann. For our audience members, we welcome your questions. Please enter them in the box provided and we'll do our best to get to them. I'd like to first start with Dr. Pan. Dr. Pan?
Great, thank you very much. And a quick significant change that just has happened this week. I just wanted to note that I am the state epidemiologist and I was the acting state health officer for several months, but I'm pleased to share that Dr. Tomas Erdogan, who's also from the Bay Area and San Francisco, is now our state health officer and state director. But I, again, am very much involved in our vaccine distribution. And I just want to say on that note, it's both a pleasure and an honor to be talking to the Bay Area Council today. Many of you may know, Bay Area is definitely my home. I trained at UCSF and worked in San Francisco for many years and then Alameda County, and have been very appreciative of the support of Bay Area Council for Public Health officials in the Bay Area. It's been really important. My relationship with Supervisor Carson as well in Alameda County and his leadership in Bay Area Council. So just really appreciate being here today with all of you. So let's go to my first slide. We can go to the next one. So I know there's a lot of questions, and as mentioned, how much have we actually, been allocated? How much have we received? How much has actually gotten into people? So as of the 4th, this is already a couple days old. I think that's pretty current still as far as how many have actually shipped to California. Over 2 million doses have been shipped. I think we're literally doing a lot of phone calls today to get the on the ground truth about, what's been received. I think that unfortunately there's some data gaps and the ability to see that. So we're doing that also and just seeing what's remaining. There are some other second doses starting to arrive this week because as many of you know, it was right around the Christmas sort of mid-December when we started getting our first doses. And this number is already been updated. So over 530,000 doses have been administered in California. We do think this is an underestimate. I think there are more doses. There is some data lag in entering into the immunization registries and other things that we're again getting more ground truth on. So I do think the number is higher, but as we've seen both here and nationally, we know we need to continue to escalate how quickly this vaccine is getting into people. Next slide, please. So we are working very hard at the state level along with our local partners to accelerate equitable, safe vaccinations for all by expanding our phase flexibility. And I'll be talking a little bit more about that in some of the next slides. We're working also very hard to create a larger pool of vaccine administrators. So again, we've all been planning for this moment for a long time, along with all of the other response to this pandemic. But unfortunately, having the vaccine come in the middle of our worst surge of all has been a real stress on our healthcare systems and our public health departments. So a lot of the people who we would traditionally rely on to vaccinate are actually very busy helping support the surge across the state. So we're working to create a larger pool of vaccine administrators, adding additional state support. We've done a big survey that we're compiling and prioritizing all the needs that are coming out of the local health jurisdictions and at the county level and city level with all of you to really understand what are the biggest needs, where are they, and how do we approach that from an equity standpoint. And making sure, of course, that as we create this larger pool of vaccine administrators, we make sure that they get vaccinated as well and vaccinated first. Next slide. So we're, again, accelerating our pace. Some of the ways we're expanding the pool is making sure that we have some agreements with the Dental Association. So dentists will be administering vaccine. We've made sure via various regulations that pharmacy techs can do so as well. The National Guard will have some people designated to do this. Again, they're split a bit between helping with healthcare surge, but also as that subsides, they will be able to be redirected to work on vaccinations with us. There's the pharmacy program you've already heard a lot about, and just as of today, there's some new opportunities that we'll be exploring with pharmacies to really have, again, more avenues to get people vaccinated. And then a lot of clinic and doctor partnerships. And there's going to be more announced about this likely later today from the administration about other healthcare system partnerships. Next slide, please. So again, we want to use every dose. As Dr. Brooks, who's on our drafting guideline, co-chairs our drafting guidelines work group, mentions, vaccines don't save lives, but vaccinations do. So we have the vaccines, now we need to make sure we get the people vaccinated. And we're really trying to emphasize to all the providers and jurisdictions that once you've covered as many people as possible in a tier, move to the next priority group while continuing to offer vaccine to all the higher priority groups. I think we've all been very conscientious, both in this state and nationally. We want to make sure with a scarce resource that we prioritize it to those who are at highest risk of disease or serious disease or exposure. But at the same time, we really want to get it out to people. And we've learned actually just over this first couple of weeks, as we've had some challenges with the ramp up, I think, again, both because of the surge and the holidays, but also the interpretation of these priorities has been very strict and wanting to make sure that every single person in that first tier has been reached, as opposed to making sure aggressive outreach happens and then moving on to the next tier while still offering. I think we're also seeing some momentum. Some of you may have heard, and a concern in general is if there's any vaccine hesitance. And we have done a lot to also provide reassurances about the safety and efficacy of these vaccines. But I think as more people get vaccinated, more healthcare workers get vaccinated, others who might have been in tier 1 might wait until they see more other people getting vaccinated, and now they are getting vaccinated. So we want to make sure people are moving through those priority groups, and I'll run through those in a minute. And then again, just making sure that doses are going to other groups when the demand from the earlier priority group subsides. And there's some unique aspects to some of these vaccines as well, that once they're thawed, you need to make sure they're used within a certain period of time. So we have to make sure these doses don't expire, and we absolutely don't want to see any waste. So balancing, again, the ability to prioritize to those who have the highest risk and in those priority groups with making sure we don't waste any vaccine and that we get it into people are super important. So we've been increasing our messaging around all of that. Next slide, please. So right now, we are in phase 1A, which the highest priority groups were designated both nationally, and this was confirmed by our local work groups and advisory committees, that healthcare workers and long-term care residents and staff in long-term care facilities are the key people in these groups. And there's actually 3 tiers in this phase. And just to quickly give you a snapshot of some of those, tier 1 is really the acute care hospitals and also psychiatric and correctional facility hospitals, again, skilled nursing facilities and their staff, so both the residents and the staff. And then paramedics, EMTs, others providing emergency medical services, and dialysis centers are all tier 1. So those were the first groups that were approached. And again, depending on the jurisdiction, as those groups are all offered to, moving down to the next tier, which is intermediate care facilities for people who need not necessarily continuous nursing, but need nursing supervision and supportive care, home health care, in-home supportive services, community health workers, including promotoras, public health field staff, and primary care clinics. And then tier 3 is other settings that have healthcare workers, including specialty clinics, lab workers, dental and other oral health clinics, pharmacy staff not working in settings at the higher tiers. And again, in general, within every tier, throughout these tiers and phases, we want to try to prioritize those who are really not able to work either remotely or are interacting with other people more as the highest priority. But again, we're realizing there's been some very strict interpretations and want to balance that priority with being able to move forward and continue to offer to all. The analogy I've been liking to use around this is it's sort of like boarding a plane. You know, usually they announce the frequent flyer million milers first, and the first class get to go first, and then the next group gets to go. But it's not, you know, if you're first class, you can still show up late and still get on the plane. So that's absolutely what we want to make sure people realize. And then what will be coming next is phase 1B. So phase 1B, this is a minor variation of what was determined by the ACIP. We again have this drafting guidelines work group that's advising us, and then they run things by our Community Vaccine Advisory Committee. So two very large groups that have been advising us at the state. So the way we've designated the next few phases and tiers for California are people over 75 and workers in education and childcare, other emergency services that are not medical, especially the front line, and food and agricultural workers will be in the next tier in the next phase. The next tier after that in phase 1B is people over 65, people in public transportation or other transportation and logistics, other industrial, residential, and commercial sheltering facilities and services, critical manufacturing, incarcerated individuals, and the homeless. And then in phase 1C, people over 50, and then people ages 16 to 64 with underlying medical conditions and disabilities, water and waste management, defense, energy, communications and IT, financial services, chemicals, hazardous materials, government operations, and community service. Next slide. So, you know, and all of this, I think, to say as well that this is absolutely the light at the end of our tunnel, and we're so happy these vaccines are here. But in the meantime, and even after people have been vaccinated, we really need everyone to continue their masking and to not mix and to not travel. People need to continue to watch your distance, stay that 6 feet or further apart, and washing your hands. I think I'm so proud as a Bay Area resident and a former local health officer in the Bay Area that the Bay Area has been a leader, you know, in the state and in the nation for really being the most supportive of public health measures and the most compliant with public health measures. So please keep it up. Really appreciate, again, the support that's happened in the Bay Area. And then the other last thing is that there's an exposure notification app called California Notify. It's the back end of that has been working with Google and Apple. And basically you can download this or just activate it on an iPhone or download it on a Android or Google phone. It's called California Notify, and it's basically an anonymous system where if you're signed up and if you get a notification that you are a case, you can anonymously register yourself as within the system if you already have it on your phone, and anyone that has been in contact with you for longer than 15 minutes and within 6 feet in your exposure period when you might have been infectious will get notified anonymously that they may have been exposed, and then they can go seek testing. So we've had, I think, over 8 million people sort of sign up for this, and several, I forget the number of notifications already. So it's another great resource, especially as we gradually will be able to open things up more after we get through this surge. That will be really helpful for notifications. So with that, I will stop and turn it over.
Great. Thank you, Dr. Pont. So with that, can I hand it over to Dr. Sue Desmond-Hellmann? Sue?
Terrific. Thanks a lot. And I, like Dr. Pont, I'm just thrilled to be sharing this session with her as also a trainee from UCSF and former chancellor. I think UCSF and San Francisco Bay Area have done a terrific job, particularly on the public health aspects of COVID, but also on the clinical care. I want to talk about the approach to making vaccines and how to think about the vaccine strategy from an innovation standpoint. The first thing I want to talk about is just how fortunate we are that the innovation of messenger RNA has become available. Both the Pfizer and the Moderna vaccines are made from messenger RNA. And that enabled both those companies to go extremely fast from having the sequence of the virus to having a vaccine. These are the first ever messenger RNA vaccines. And so what does that mean? It means that they could direct specifically the vaccine to this virus and do so much more quickly than anything we've done before. It also means that they have to reconstitute the vaccine in a medium, in this lipid medium that has required very cold, in the case of the Pfizer BioNTech vaccine, or cold storage. And you just heard from Dr. Pan how what that impacts is that you can't leave things unrefrigerated, and there's a pretty rapid expiration. It's also going to be very tricky to get these vaccines to any very poor settings, for example, in India or Africa. And so there are limitations to this first generation of messenger RNA vaccines. The good news is that these companies are continuing to work on the delivery and the storage and the supply chain for the vaccines to make it as easy as possible. So I would predict that these will be easier in the future. But right now it is very tricky, and special refrigerated storage has been made available in order to get these shipped out. The other thing to mention with messenger RNA, and if you remember your biology, the messenger RNA is directing your cells to make the spike protein of the virus, and then you make an immune reaction to that. It's actually a pretty cool thing. So if the virus is able to mutate in a way that it escapes the vaccine, which has not happened, people are carefully monitoring to make sure that hasn't happened. But should that happen, it would also be possible to go back and again rapidly make a vaccine using messenger RNA towards whatever the antigen is of interest in order to create a new vaccine. And so I'm really excited about the messenger RNA as a platform for making rapid vaccines. We've never had anything done in less than a year, which is the case for the Pfizer and Moderna vaccines. The record, so to speak, before that was mumps vaccine done in 4 years. So it tells you how much more rapidly these vaccines were made. The second thing I wanted to talk about besides innovation is I want to talk about equity. One of the things I loved about being CEO at Bill Melinda Gates Foundation was all day long, I thought about equity, about equal access to things like vaccines. As I mentioned, one of the concerns about the supply chain is that we need to get vaccines, not just to everybody in the US, but everyone globally, for all of us to truly be safe. One of the things that I think was a good news item with the Food and Drug Administration and CDC and their interaction with the companies about how these initial vaccines were approved is that they pushed the companies hard to make sure that they addressed equity as quickly as they did the clinical trials. Pfizer moved from a 30,000 patient population in their phase 3 trial to 44,000, specifically to make sure that they increased the diversity of the patients who were being vaccinated. That's especially important given how serious COVID is in people of color and in populations who, for a long time, we've known have had worse outcomes in our medical system. And so the 44,000 patient population allowed them to make sure that we included patients, Black patients, patients who were Latinx. And so that was done in the clinical trials. The other equity component of making sure vaccine is available for all is that two companies' vaccines aren't enough. You see the tiering that's required right now. The good news is the AstraZeneca Oxford vaccine and the J&J vaccine should have results coming out in this first quarter of this year that would allow those to be added to the mix of vaccines. And J&J's vaccine should be a single dose vaccine. And so this increase in the number of manufacturers who have available vaccines will also help with the equity piece and with the coverage of who can get a vaccine. The last thing I want to talk about before we turn to questions, and I saw there's already a lot of really great questions, I want to talk about speed versus safety. One of the things that I think is unfortunate, especially when you talk about vaccine hesitancy, is that even the moniker Operation Warp Speed made people nervous. That, are we going too fast? Are we cutting corners? Are we taking shortcuts? I've spent a lot of time in my career in product development, in doing clinical trials. And I can tell you that these clinical trials are crossing every T and dotting every I. They are answering safety questions. They are large patient populations, and the FDA, as they should, has been asking tough questions about safety and efficacy. The initial 2 vaccines got emergency use authorization, not a full approval. And that's because the follow-up was 2 months, not a year, not a long-term follow-up. So I think an outstanding question that remains is long-term safety, long-term follow-up, and people should know that. But in terms of carefully making sure every patient is followed and making sure that the rigorous standards that we all expect for vaccines are completed, that's what I've seen done. And I think we should expect that, and that's the good news. So balancing the need for speed in the face of a pandemic with the need to be very careful about safety so far has been done. So let me quit there, and maybe we'll turn to questions. Thanks for listening.
Great. Thank you, Sue. I'm keeping an eye on the questions that are coming in. I think I'm going to skip the first couple of questions that I think you have addressed along the way. There is, for Dr. Pan, much attention focused on the rollout of COVID. Give us a brief update. I think, Erica, you addressed that nicely. And I think, Sue, there was a question around hailing the development of the vaccines as a miracle, and why is that? What made it so remarkable? And you talked about the messenger RNA for the first time, and in the past 4 years versus months this time. So I'm going to go to a couple of others. To Dr. Pan. There have been concerns and criticism that California's rollout has been slower than other states. What is the state doing to address these concerns, and what does it mean for the ambitious timeline for distributing the vaccine?
Sure. So I think I touched on that, but I would say actually, as I both look at the data nationally and am on calls with my partners, that we're actually definitely up to, very similar to other states as well. And I think I actually want to highlight something else that Dr. Desmond-Hellmann mentioned as well about speed versus safety. I think this is really important, and I'm really glad she highlighted that, not only for the actual vaccine trials and making sure they're safe, but making sure we are doing this right when we get this vaccine out. And, I have already heard, and we're getting some situations where when things are rushed, and people have heard, right, in another state, they gave the completely wrong product. They gave antibodies to people who weren't sick. So, I think we really want to make sure that our healthcare providers and, people that are providing the vaccine are doing it. They're planning ahead. They're setting it up in the right way. They're watching people afterwards, So I think that's a really important component as far as, so I think there's both a ramp up time and also making sure you're doing this safely. And I think the other big sort of difference between, we've done lots of mass sort of flu vaccinations over the years and planned a lot for pandemic flu vaccine clinics, but no one ever had to plan for this sort of physical distancing during a clinic as well. So it's just a whole nother element. And again, having people stay on site for longer afterwards. So I think what I was highlighting were all the things we are doing to accelerate. We're really kind of surveying the state and seeing where the biggest gaps and barriers are needed. We're getting more vaccinators, really kind of formalizing those relationships and partnerships to see what we can do at the state level as well to augment all the efforts of our local partners.
Great. Thank you. Better safe than sorry. So Dr. Desmond-Hellmann, next question. Given the shortage of the vaccines, what if someone only takes one shot? I know there's so much in the press been written, Washington Post article as well. Are there any benefits to taking just one shot?
So that our local chief of medicine, who I have enormous respect for, Bob Wachter, co-wrote the Washington Post opinion piece, and I think he and Dr. Jha were very careful to say, we're putting this out there for discussion. I don't think it was a recommendation. It was like, should we think about using one dose? It's been observed that in the Pfizer trial, if you look at the curves, there's clearly protection as much as 80% after the first dose. What we don't know is how long that protection is, and how prolonged protection depends on the second dose. I will give my personal opinion. This is a personal opinion, not Pfizer's opinion, not anybody else's opinion, but my personal opinion is 2 doses. We do clinical trials because we follow the results. And these clinical trials were brilliant, 95% efficacy. I want 95% efficacy. And so I want people to get the second dose. I do think we're going to gain momentum. I think people are going to figure out how to vaccinate and get more vaccinators, as Dr. Pan has said. So I'm very optimistic that we'll tackle this vaccination problem, but I tend to follow what was done in the clinical trials because that's where the safety and efficacy is derived from. So FDA came out after the Washington Post article saying you should do what it said in the trial and what it says in the label. I'm with FDA on this.
And can I jump in for a moment too? We
Sure.
actually asked our, I don't remember if I highlighted yet, but we have a Western State Scientific Safety Review Group that we actually asked because of the concern, as was alluded to, when you even call something warp speed when it comes to, and concerns about speed versus safety. We also wanted to convene a California group, and then a couple other states actually wanted to add on, because we're so lucky again in California, we have national experts like Dr. Desmond-Hellmann and others. So we have convened that group, and there are members on our California group who are members of the FDA VRBAC and the CDC ACIP committees, and asked them this very question because it's been a hot topic and something of interest as a strategy. And they agreed actually with the FDA statement and Dr. Desmond-Hellmann that right now we don't have enough data to support that, and that really what we want to focus on is again, increasing our distribution and getting vaccinations into people, and that if the supply continues to increase as we anticipate it will, and our efficiency, that we should stick with what the data does show, because again, that interval, it's unclear what would happen in that interval if you don't get the second dose, or even if you delay it for too long. So that they're coming out with a formal statement that we'll be posting as well. But that again was a group of experts in California with a couple of representatives from Washington, Oregon, and Nevada as well.
So the next question is really directed to both of you. So the vaccine is great and it's breakthrough science, but it only works if people take it. So how are companies like Pfizer and the government working to overcome public fear, skepticism about taking the vaccine?
You want to, after you.
Sure, no, I'll start. It's when people ask me before the vaccine even came, what was I most worried about? This is the issue that I'm most worried about, especially given vaccine hesitancy prior to this. And I will say that what we are doing and what has been really helpful to see over time is a lot of sort of various surveys, focus groups, and work with different communities, working a lot with trusted community leaders and messengers to, again, reassure them about the safety and efficacy, and working with community leaders, community-based organizations to know what are, who are those trusted messengers, and how can we make sure we're communicating this in a way that people understand and can trust. We of course understand that trust is an issue as well. It's another reason as well that we developed all these work groups to advise the state health department and the administration. Everything from that scientific safety group I mentioned, we have a very large community vaccine advisory committee, and we have those public meetings actually periodically to talk about these allocation guidelines and the tiers and make sure we get input on that. So there's a lot of work going on with that, more community engagement, again, both at our level and then really at the local level. I think it's even more important for, at the local level to be, again, seeing who's trusted locally and working with them to make sure they have good materials and messages to be able to share, to work on that. And I think, again, there's a momentum. I've just anecdotally heard as well, even among healthcare providers, some people who in the very, very beginning were like, oh, I'm not so sure, but as they see all their colleagues getting vaccinated. So I do think both anecdotally and in polls that the acceptance and is growing, and I think we need to continue that, because it is true, to get beyond this, we need, we don't know yet the exact number, and Dr. Desmond-Hellmann may have thoughts on this as well, but we need, certainly a large majority of people to get vaccinated before we can really get beyond these measures that we're doing as far as masking and distancing and getting back to our normal lives.
Yeah, boy, do I agree with that. And the one thing I would add to what Dr. Pond said, which is so well said in terms of community engagement, the Gates Foundation collaborated with UNICEF, Rotary, WHO on polio, including in northern Nigeria. I mean, talk about degree of difficulty. And we were also involved and collaborated with a lot of folks in West Africa when Ebola broke out. And there was so much I learned from every community. There's someone you believe, there's someone you trust. It might be the imam, it might be the guy who runs the local grocery store, it might be the school teacher who's been there for years and years. It's not always the same, but knowing who's trusted and working with them and being really thoughtful is essential. I've loved all these pictures of people with their biceps out getting a vaccine. I think you can't do too much of that. So just the sense of momentum, as Dr. Pond said, and the sense of like, this is a community thing, and having that engagement that we're protecting ourselves. It is going to be a long time before we will all get comfortable that we don't have to wear a mask or distance, wash our hands, not travel. And I think the journey towards there, creating some momentum and knowing that we're all increasing our chances of getting there, I think will help people get more comfortable.
All right. So the next question, Dr. Desmond-Hellmann, I'll just stay with you. How is Pfizer scaling up production of the vaccine? Are there sufficient doses to meet the overall need? And does the production timeline match the distribution goals set by public health officials? I think you touched on this a little bit in terms of getting, additional companies, additional options, but let me hand this to you.
Yeah, so having more than Pfizer involved in this is a real positive. Pfizer themselves have done a number of different things that in some cases they've been limited by raw materials. And so they're working with the federal government to make sure that anything that can be done to get them the materials they need is possible. In terms of their manufacturing sites, they have been flat out since they could be flat out in 2020, and they'll be flat out in 2021. Just as the case with doing mass vaccination campaigns in the face of social distancing and all of the COVID things, the other thing they've had to be really thoughtful about is making sure that they protect their manufacturing staff so that they don't have any outbreaks in manufacturing, because you can't work from home in manufacturing. And so they have just systematically done everything they can, both in the US and in Europe, in their manufacturing sites to maximize their output.
Thank you for that. So the next question, and I see a lot of questions coming in, so audience, please keep them coming. I'm trying to align them thematically. So this is one for both of you. What has the level of coordination been between the federal government, the pharmaceutical companies like Pfizer, and the states in rolling out the vaccines?
I can start for sure. I think there's been a lot of coordination. A lot of it has happened through sort of federal government. So again, Operation Warp Speed and the CDC. Actually at 12:30, we're having a call with General Pena from Operation Warp Speed. So we get periodic sort of higher level communications like that. And then on the immunization sort of director level, there's immunization program from CDC talking directly to ours. There's town halls periodically. And then likewise, just to say that translates locally too, from the state level, we then have the similar analogous communications with our local health departments and local representatives and local healthcare providers that are getting the vaccine. So we try to in turn do that sort of weekly lately. So there's been a lot of coordination there. And I do know because we're, again, thankfully a large state, that Secretary Galley has been able to have direct conversations as well with the manufacturers as well. So I think there's a lot of coordination. I think, like everything else, I think, communication is key, and it can always be more and better, but there's been a lot of coordination.
Yeah, I would second that. And I would add two things into this mix. One is that the Food and Drug Administration has also been extremely involved and I think proactive as the vaccines have been approved, to make sure that they do everything they can. They have done heroic things to get the labeling, to get all the information out. So FDA, CDC, HHS have all, I think, done a great job of coordinating. Not perfect, but this is fast and over the holidays and in the midst of an epidemic, so it's hard. The thing we haven't talked about, but is important to keep in mind, if you're Pfizer or if you're Moderna, you're also getting orders from the EU, from the UK, from India. So there's a global supply chain that is present, and there's an approach called COVAX, where multiple countries, Gates Foundation, WHO, and others are coordinating and collaborating. I think they have $2 billion now to try and get the vaccine out to countries that are low resource, because that is something that has not been done yet and needs to be done.
Terrific. All right, moving to audience Q&A that are piling up. First one, some of these will be a lightning round, so whoever wants to take it. Any evidence that vaccinated individuals will still be likely to transmit the COVID-19 viruses?
We don't know. We need to follow up and need to find that out. We know they're less likely to get sick, especially very sick, but we don't know if they're less likely to transmit. Okay, great, thank you. And if any one of you wants to also answer, just put up your hand. If not, I'm going to keep going. Dr. Pan, you mentioned the tiers, and our audience wants to understand this, and I guess it's not entirely clear, the question, but their basic question is, do homeless and criminals get the vaccines before people who have cancer and are immunocompromised? A lot of ethical issues in those decisions.
So I think the way we'll respond to that is, I think, there are a few factors, of course, many factors that go into these decisions. And again, there were some national frameworks, and then we took some next steps here in the state. And I think we need to think about the high risk of exposure, the risk of exposure, the risk of spread to others, and then the risk of serious disease, right? And trying to balance all of those, both for just overall infections, hospitalizations, and mortality. And I think, we do know that congregate settings are where there are outbreaks and where disease spreads very quickly. And the highest mortality of those are the skilled nursing facilities and nursing homes. And then other congregate living settings, including jails and homeless shelters, are where we've seen outbreaks that then spread to the whole community. So I think it's really where we, I also think about, where you're putting out fires, basically, and you need to kind of put those sources out first. And so that is one of the rationale behind that. And again, all these are very tough decisions. And I think, again, as we get more supply as well, we'll be hopefully moving through these tiers and phases more quickly as time goes on.
This next one I'm going to direct to you. Is the Moderna vaccine as efficacious as Pfizer in over age 65? Were findings in trials statistically significant?
So there are no head-to-head studies of the Moderna versus the Pfizer vaccine, but in these large trials, the efficacy of each of the vaccines was very similar. And one good news item in both trials was that they both seem to be as effective in the elderly as they were in younger patients, in younger subjects. So they seem very similar, and their biology is very similar.
Great, thank you. So this next one, I think the first part of this question, Dr. Pond may have answered with the tiers, but the second part, I'm gonna state the entire question. What is the anticipated time schedule for getting the vaccines out to the different tiers? Also, when will we find out if there will be a need for this to be done annually for continued protection?
Sure. So as far as the timeline for the schedule, I think the important thing in California, especially again, huge, diverse state that we have, is that, you know, different jurisdictions and communities are going to be at different phases and tiers at different times. I think right now, again, the focus is this first tier, but I think there are some smaller jurisdictions that have really may not have a lot of healthcare workers and or skilled nursing facilities that already have used their allocation and are ready to move forward. So it's going to really vary. I do think the vast majority of California is still in phase 1A. And I think, you know, after we get more supply, I think the other thing I can just share as far as numbers is, you know, we estimate that first phase 1A is probably about 3 million people. And again, we don't know it's not 100% acceptance or rate at this point. So after we've gotten you know, this first sort of bolus of vaccinations into people, I think that we'll feel even more comfortable with it. It's time to move on. So it's going to be really a dynamic thing though, and there's going to be different jurisdictions and different phases, because you can imagine as well, like looking at tier 1 of phase 1B, there are certain parts of, for example, the Central Valley where they're going to have a large number of agricultural workers, whereas some of these smaller rural jurisdictions may not and might be able to move on to tier 2 earlier. So it's going to be dynamic and really depend on the local community and how many are in each of these populations locally. The other question, yeah, I think Dr. Desmond-Hellmann may have some response to that. I think it's too early to know, but I'm sure she may have some other perspective as well.
No, actually, we don't know, and it will be essential to follow the patients who've been in these trials to look at how long their immunity lasts. One of the things that's being done now is, as these same tiers are coming forward for the community, they're also coming forward for the patients treated with placebo in the trials. So if you were a healthcare worker and you were in the clinical trial, you now will be offered the vaccine if you got a placebo. And so that will diminish a little bit our ability to learn from the trials, but we'll still be able to look long-term at immunity. But we don't know yet how long the vaccine will protect.
You just answered the next question. How long will immunity from 2 doses last, and what does the current data show?
We have such short amounts of data. We really don't know.
Again, another question for you, Dr. Desmond-Hellmann. You said Pfizer is limited by raw materials. Which raw materials?
Actually don't know that I can articulate all the details of what they're missing. And I think they caught up with that. So the thing I want you to know is they are on track to provide, I think that's over 1 billion doses in 2021. But that was rate limiting at one point for them. But I can't tell you which ones they were.
What information do you have on the China and Russian vaccines? The Chinese and Russian vaccines?
I don't have any additional information. The one thing I know that China is trying to make its vaccines available outside of China for multiple countries, like they started with Brazil and others. But in terms of safety and efficacy and any peer-reviewed publications, I've not seen any. I don't know if you have, Dr. Pond.
I haven't been tracking that as much either, but I have not. Yeah.
This is a specific question. When do cancer patients who are not undergoing active chemotherapy become eligible to receive the vaccine?
So again, once we get into phase 1B, there's a mix of things, right? So if you're a cancer patient, you're over 75, or you're a cancer patient over 65, you're gonna actually be eligible in those tiers. And so I think it's going to be age dependent as well. And again, I think we're really trying to emphasize these are principles and priorities, and there's going to be some variation. And we certainly, we have come out and we feel strongly as well about if people are really violating these core principles, sort of paying to jump ahead of the line or things like that, we absolutely want to be able to enforce that and make sure that's not happening. But I think, certainly, again, a way a lot of these decisions were made is looking at overall, as far as these guidelines and what is the morbidity or mortality of a specific an exposure as well. So tried to do our best on that. I think for individual patients, if a clinician thinks that a certain patient is as high risk as a 75-year-old, they could be able to make that decision in that moment. You're on mute.
Oh, did I get? Hold on. Can you hear me now?
Yes.
Okay. Let me move on thematically to something slightly different on the variants of the coronavirus. It's been reported that there's been a new variant that's appeared in South Africa after a more transmissible variant that originated apparently in UK. It was found in California last week, or maybe the week, or maybe last week. How confident are you that the vaccines can protect against these new variants, and what is the likelihood that we could see a more deadly or vaccine-resistant variant this year? I know, Dr. Desmond-Hellmann, you talked about the messenger RNA and the fact that it causes the production of the spike protein that then causes the immune reaction, but then you also mentioned about some changes around that. So let me hand this to you.
Yeah, no, the up to now, the variants that have been described in the medical literature, the biggest concern is that they're more transmissible. Up to now, we don't have evidence that any of the variants escaped the vaccines. We don't have any evidence of that. So far, that is very concerning. I don't want to underestimate how concerning it is that it's more this is a very transmissible virus. But so far, we don't have evidence that it would escape the vaccine. I don't know, Dr. Pond, if you want to add to that. I think it's a really important question. We have limited sequence data, but more scary on transmissibility, not vaccine resistance.
Yeah, I think I would just add that the most important message for the public is that our best prevention is still all these other measures that we're talking about as well. And that I have not heard that there's been any variants that have that there's concern there wouldn't be. And I can just briefly tell you, we do have sequencing networks across the state and the country, and continuing to look at that. So we are following that. It is just a subset of the testing that gets to do that fingerprinting to see, and we anticipate there will be more.
And the next question, once someone has been given the vaccine, does life go back to normal, or are there still precautions to be taken?
I'll start and say that, unfortunately, no. I mean, again, we need everyone. We need almost everyone to get vaccinated before life can really be returning to normal. So our recommendations, even after you're vaccinated, even after that second dose, is that you still need to, wear your mask, watch your distance. And Dr. Desmond-Hellmann already answered the other question about, we don't know yet if you can still be infectious to other people. We know we decrease in the seriousness for sure of the disease, and that less people are infected with who are vaccinated, but we don't know as much about whether you could still transmit to others.
Yeah, that's it. We will be using masks. I need to wear a mask background. I love that. We will be using masks and distancing and washing our hands, and things will not be back to normal for a long time. And part of it is getting people vaccinated. Part of it is understanding how long the protection is and what the protection consists of. So for people who get their vaccine, they still need to follow all the guidelines.
Great, thank you, thank you. Let's see. This is an interesting question. What does the development of this vaccine portend for future vaccine development, including for other ailments and diseases, both from an R&D perspective and a regulatory review and approval standpoint?
So I think that the pace of this vaccine's development and the innovation involved is a real plus. And it also stands on the shoulders of prior vaccine work that was done in things like SARS and MERS and other infectious diseases. So they, not only for vaccinology, but particularly for vaccine development, I think that this, and not limited to mRNA, the adenovirus construct, some of the other approaches to vaccine development have also been the subject of innovation. So I'm really positive about what this means for the future of vaccine development. I'm a little less optimistic that you can serially do something like a year and parallel track everything. There were two things that made this possible that are not scalable. One is money. Operation Warp Speed spent billions of dollars, like a lot of money, to make things go this fast. And the second is the parallel processing, which is related to money. So if you told Dr. Pan and I to start a company and make a vaccine in a year, we would have to manufacture at risk. We would have to make bets on this versus anything else in our pipeline. It's just the kind of capital it takes and the kind of risk it takes is super hard. And I say that with regard to the regulatory path, because the compressed regulatory path just took that capital investment and risk. And it also took nights and weekends for everybody at FDA, which is not sustainable. So I don't think it'll be 10 years like your average vaccine in the old days, but I don't think it's going to be a year.
All right, so coming down the home stretch here. This one's for Dr. Pan. Do we have enough healthcare workers to administer the vaccine fast enough, or does something need to change? I think you teed it up initially about sort of recruiting the pharmacists, others in the effort, but let me hand this to you.
I feel like I covered it. We have a stretch right now in healthcare workers, so we're really thinking beyond the workers that are, we would normally be leaning on more to do the vaccine, and really thinking more outside the traditional vaccinators to really expand that reach. And I think also as this surge subsides, which we will get through the surge, we will be able to redirect more people. So again, a lot of the federal assets, for example, again, and I think I mentioned some of them, are really focused on surge right now. And then I think that can be shifted to have more vaccinators. But in the meantime, yes, we're really expanding again to make sure that there's a lot of people that don't normally give vaccines that we recruit and get to do that.
Let me just close with the following question to reflect on for both of you. Given the many unknowns, how short the testing's been, how quickly it's come, one dose or two, who's going to get it, who's going to take it, the efficacy and so forth. Relative to the vaccine, what are you most optimistic about for 2021?
Oh, I'm optimistic about coverage. I think as we get to, I think we need to, and we will get to really high levels of coverage, and we'll learn more about duration, and that's our path back to normal. So I'm optimistic about starting to see the light at the end of the tunnel.
Yeah, no, I think likewise. I think it's been a long tunnel. I was just reflecting with someone else, in public health, we activated in January of 2020 as we started hearing about, this disease in Wuhan, and started monitoring travelers from Wuhan. And so it's been a long tunnel, and it's so exciting to have the light. And it's, as we've both been talking about, we think, we have a tunnel ahead of us still, but we can see that light, and it's really great that it's here, and it seems like it's getting bigger and stronger by the minute, and we're really committed to to continuing to, you know, get to that light. So I think I'm really excited that, yeah, we have had these amazing, you know, rapid developments of vaccine, and that more is coming, and that, you know, and I think the last optimistic thing I would say is, I don't know that any of us thought not only that it could happen this quickly, but 95% efficacy for 2 different first vaccines is really huge. I mean, anyway, so that's really exciting, and something we're all really, really grateful for.
Thoughts that that you would like to share with the audience?
I think I would just say again that I'm really proud of California and Californians in the Bay Area, and you know, thank you all for all that you have endured over the last year as well. And just please hang in there a little bit longer, and please continue to follow these public health measures. And this is our light, and we are going to get everyone vaccinated. And please, you know, be a trusted messenger for us as well, that, you know, as vaccine comes, to make sure people are getting vaccinated, and we will get back to normal. And you know, thanks for your patience, and just continue for a little longer, and we can get through this together. So thank you, everyone.
Yeah, I just want to express my gratitude to everybody who's in public health and in the clinical care system, and people who are, you know, driving buses and at the grocery store and everything else, who can't work from home, who are doing incredible work to keep us all moving during this pandemic. I'm just really grateful for all of that. And I'm also sympathetic to people who are tired. They're tired of being alone and tired of being sheltered and following things. It's almost like I want all of us to take a deep breath and say, we can do this. We can do this. That's why the light at the end of the tunnel is so important. So maybe a lot of gratitude and some sympathy for how hard it is to hang in there.
Thanks everybody for attending our Impact webinar series. And you heard it first here from our state epidemiologist and from Pfizer Board Member, amongst many other titles. Personally, I'm just really thrilled to be sharing this forum with you. I found it very insightful, very interesting, and I hope our audience did the same. So with that, we will conclude. Thanks again.
Thank you. So long. Thank you.
Bye-bye.
Bye.